Hello and welcome, everyone. We're going to give it just a second because we've got folks still joining, but we'll jump right in momentarily. All right. Thank you all so much for joining today's webinar. We'll be talking about ethics and COVID and equity. My name is Lauren Berner, and I'm the Senior Research Manager at the Council. I use she, her pronouns, and I am based in Nashville, Tennessee. We want today's conversation to be just that, a conversation. So to get us started, we'd love if you could just take a moment and introduce yourself in the chat. Just make sure you select everyone so that everyone can see who's with us today. Before we jump in, we just have a little bit of framing and housekeeping to get to. So Katie, we could jump to the next slide. This activity is funded by a cooperative agreement with the Health Resources and Services Administration through the American Rescue Plan, but the content of this presentation is not necessarily endorsed by HRSA. So the next slide, please. If you're not familiar with the Council, we are a membership, training, and advocacy organization focused on supporting those who provide care at the intersection of health and homelessness. Our mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. Next slide. This is a meeting-style webinar today, so this is your kind of run-of-the-mill. If you are joining a conversation with folks, that's kind of what you should expect. So you are welcome to unmute during our discussion, to be on camera, to type into the chat. We'll have that conversation space at the end. If you are not talking, we do ask that you mute yourself just to limit some background noise. I know that there's a high likelihood that you'll hear dogs from me, so I will try to be on mute when I'm not speaking. But know that that's kind of the world that we're in. So next slide, please. I am joined today by some wonderful colleagues and providers in our community. I will let everyone introduce themselves and hand it to Katie.
Hello, everyone. Welcome. My name is Katie League. I am the Behavioral Health Manager here at the Council. I use she, her pronouns. I'm so glad to be with you all. And thank you for joining. I'll hand it off to Kavanya.
Hey, everyone. My name is Kavanya Elzia, she, her pronouns. I am the Director of Justice, Equity, Diversity, and Inclusion. But my background is as a registered nurse in a variety of settings, included permanent supportive housing. And I am in Seattle, Washington.
And Omar.
Omar, yes.
Hi, everyone. My name is Omar Majero. I am the Director of Operations for the Barbara McGinnis House. In my role, I am overseeing all non-medical departments within our respite program. I'm a social worker, and thank you for the invitation.
Thank you so much for joining us, Omar. And thanks to all of you who are introducing yourselves in the chat. I'm excited to hear more about the work that you're doing towards the end of our time together. All right, next slide, Katie.
Hey, Michelle, do you mind if I?
Thank you. So our agenda today, we're just gonna take a few minutes for framing, and then we will move into some case examples and then have plenty of time for conversation. As we're talking through the examples, we would love to hear your thoughts, or if something similar has happened to you in your community, please feel free to share that in the chat, and we'll definitely have time to have some conversation together. Next slide. All right, before we jump into those examples and discussion, again, just taking a couple minutes to set a foundation for our time today. We're going to just define some of the ethical principles that we're using to think through what ethics means. First being autonomy, or respecting individual choice. beneficence, doing the most good, justice, distributing resources equally, and non-malfeasance, doing no harm. Each of these represent the internal process that providers and the HCH community are using when we navigate making decisions, especially difficult ones. And you might find that you lean into one principle over another, especially if those decisions or principles feel conflicting. So how are we balancing what one person wants when that choice may harm someone else? For example, if someone is in the COVID context, not willing to isolate, but is willing to stay in a congregate shelter, do we embrace their autonomy? If so, do we require things like masking or regular testing to protect others? In some listening sessions we held last year, we found that when working with people experiencing homelessness, a lot of providers really lean into autonomy since folks may have limited choices because resources are limited. All right, next slide. Going to hand it over to Katie to talk a little bit about other ways that we're going to chat with each other.
Yes, so this is a chance for us to hear from you all through a different medium. If you've attended a webinar with us recently, you may have used this. It's called Mentimeter. We just love it, and it's a really great way to hear from you without a different way, so that for those who may not want to come off of mute or don't have the ability to type in the chat, this is another way to engage. So there are a few ways in which you can log into this. The first is if you have a smartphone or any device with a camera, if you put it over that QR code on the right of your screen, open up the camera and put it over the QR code. Don't take a picture, but just a yellow box should appear, and then you can click on it. You can also go to www.menti.com and enter that 8-digit code. And we may have another link. I'm not sure if you have it available, Lauren, but if the direct link, but if not, those are two ways to do it. And you will see that 8-digit code on every slide that we use. And the really cool thing about this is that as you answer, we will all see your answers on the screen. So let's dive in. The first is we want to hear from you when you hear or when you think of moral injury, what comes to mind for you? When you hear that phrase or when you read about it or when you engage in conversation, what are the things that come to mind for you? Give everyone a few chances, a few minutes to answer. Yep, the system that creates homelessness in the first place, working in healthcare, COVID in particular. Yes, yes. If you are unable to use Mentimeter, just don't want to open up another thing, please feel free to answer in the chat as well. Lauren just dropped the direct link, so that is also another way in which you can get to it. The thing about Mentimeter is it's anonymous, so if you want to say something that you think is either controversial or you don't want attributed to you, Mentimeter is a great way to do it. Yep, a whole lot of BS, discrimination, particularly currently, banning of books, erasure of lived experience, great input, actions that causes injury to my heart and spirit. Oh, man, I feel that. That answer is, wow, that speaks to me. And boy, do I feel that. Deliberate cruelty from our policymakers. Yeah, lots of recognition of the systems that cause the pain. I think going into our work, we accept, not that we like, but we accept that there's going to be a level of pain in empathy that comes with caring for and having the privilege of working with individuals experiencing homelessness. As humans, the vulnerabilities we open ourselves up to one another, we're maybe in some ways ready for that type of pain and injury. The pain that comes, the moral injury comes from the systems that perpetuate that hurt and allow the discrimination and injustices to continue, despite knowing exactly what they are and what the causes are and how to end them. Thank you for those who jumped in.
So as we kind of saw, there's a few different ways that we identify moral injury in ourselves. And I see there's a few in the chat as well, kind of being put in a position where you have to compromise your values and a system that doesn't provide any answers and solutions. And so I wanted to really just share some of the different ways that we can think about moral injury. But there is a common thread through all of these where you are faced with a decision that doesn't have a good outcome. You're forced to make a choice that goes against your belief in what is right, your moral values. It can be one incident, it can happen over time, but the result is that there is a psychological, biological, cognitive, and/or emotional impact on you as a result of having to be in this space and make that choice. So it's more than just kind of burnout, which we hear a lot about burnout, but it's really your whole body and yourself reacting to the situation that you've been placed in. I mean, I really appreciate the emphasis in this conversation on how so much of that is a systemic issue that is impacting our ability or inability to make decisions that we know or feel are right. So next slide. So as we think about kind of how ethics and moral injury and COVID and the HCH community kind of all come together, we really wanted to highlight the fact that providers are really navigating these incredibly difficult ethical decisions, especially early in the COVID pandemic and continuing on, and really thinking of the experience of moral injury as guilt or shame or self-condemnation that may fall into this space. The APA released a report on specifically looking at moral injury in light of COVID-19 and highlighted various sources of that moral injury that providers may have experienced, including rationing of scarce resources like ventilators, triaging folks based on who was believed most likely to survive and what that impact looked like on our patients. The added complications of trying to provide care for your own family while also trying to limit personal interactions to minimize exposing loved ones to COVID, and the amount that wore on staff and continues to wear on staff. Challenge of navigating administrative and policy decisions that may be the best option for the health center as a whole, but can also leave providers facing impossible decisions. Not being able to provide care to those who need it because of COVID, and primary care providers navigating what happens when needed procedures and resources are considered non-essential, leaving no referral options for many specialty services during this time. And personally, providers navigating the duality of guilt for not being able to work if you caught COVID, but also the stress of having to pick up extra work when your colleagues are out sick. For many HCH providers, the moral injury and burnout during the COVID pandemic was really just compounding on what you were already feeling working in resource-limited environments. So also balancing the personal and family resources and caring for those that you serve and feeling powerless in the face of these larger systems, but also acknowledging your own privilege as well as the emotional toll that the work takes. It's a lot of conflicting and challenging emotions that we've been navigating long predating the COVID pandemic. And so I just wanted to mention here that it's ever more important to find ways to continually support ourselves and our staff, and providing opportunities to engage in actual self-care and providing tangible access to psychological support in this space. Next slide, please. So I wanted to just hand it back to Katie for a moment.
Yeah, so that same link, if you still have that screen open, otherwise the link that Lauren dropped in the chat or going to menti.com will get you to the same place. But hopefully for those who still have it open, this question will appear. Want to know, when did you first hear the phrase moral injury? Pre-COVID, during COVID, Today's the first time. Quite a few of those today's the first time. That's great. Thank you for. I'd love to hear for those who say today's the first time. As we've talked about it, is this something that has resonated? You've talked about the experience of it, but now this is giving the label to it or a name to it. If that's the case, I'd love to hear in the chat, and certainly when we talk in the discussion, how much has it been that you've known the feeling and the sentiment, but didn't know that there was a name for it. So not surprising that we were talking about this as a group, that we said we felt like it's really something even we at the council have really talked about much more since COVID, that this has been something that to me, when I heard it, it resonated so deeply as something that I had felt in my social work practice. And I was at Healthcare for the Homeless in Baltimore for 9 years before joining the council. So I knew the feeling and had never had the term paired with it or recognized the impact of it. When Lauren shared the previous slide with us as we were preparing for this, it kind of knocked me off my feet in the ways in which, yes, this is trauma. There's a reason this is so difficult, and this hurts in a way that is different than other emotions we feel in our work. Thank you. We're going to move on, but if anybody else, please feel free to utilize the chat to chat about this, and we'll definitely come back to it.
Thank you, Katie. We also wanted to really think about how the impact of COVID and moral injury is further compounded for staff and patients of color. The Center of Excellence for PTSD in Canada and the Center for Post-Traumatic Mental Health in Australia put together a supplement to a guide that they created on moral injury and COVID that specifically focuses on racial inequities and moral distress. Just kind of another term in that moral injury realm. And so I just wanted to highlight a few points from this document, but know that there is so much more to this that we could talk about. So if there are things missing, please feel free to type those into the chat as well. And so when we think about the impact specifically on clinicians of color, we have to acknowledge the role of systemic racism and the stressors that predate COVID and were further perpetuated by it, and those that were created by COVID too. We know that clinicians of color have the lived experience of racism, both in and out of the healthcare space. And so when this is paired with observable differences in COVID outcomes and the already stressful experience of working in healthcare, added to that, the experience of working in healthcare during COVID, there is that increased risk of the moral injury that folks may have. We also must consider the toll that it takes on clinicians who are serving their own community, especially if they are one of few staff that reflect their community. That may feel like pride and purpose and being able to provide care for people who look like them. But that is an added responsibility, and that added responsibility can create burden, especially, again, if you are one of few who are able to relate and who are trusted. And that added burden can impact your mental health and well-being. Next slide, please. And then also acknowledging that our patients were also experiencing this moral injury and trying to decide how they access care too. And so thinking about BIPOC patients, they are also experiencing a health system with a history of ethical failings and significant disparities, which is understandably making it difficult to trust. And when marginalized communities are subject to unethical practices, for example, famously the Tuskegee syphilis study and the use of Henrietta Lacks cells in research, it's reasonable to be skeptical of new treatments. And providers really need to think about how we can demonstrate that we can be trusted rather than expecting to be trusted in these spaces. As I mentioned before, we also see the impact of disproportionately poor COVID outcomes in racialized communities. This is built on past disparities where we see communities experiencing higher rates of comorbidities that put them at greater risk and are in spaces that are historically created to have fewer resources. We also have to examine who guidelines and practices are considering when we're determining if they're ethical and fair. I linked on this slide a report from England looking at who is considered higher risk and in essential jobs and putting them at greater risk for COVID because of their occupation. And then also looking at population density in communities where social distancing is more difficult. And they were finding that people of color are overrepresented in both of these categories. So other ways to think about how our policies and our guidelines and our practices are impacting our patients and whether or not those are ethical can include things like crisis guidelines. And I know Katie has a specific example of that she is going to share with us. So I'm going to hand it back to her.
Thank you, Lauren. Yes, Lauren referenced this a little bit, but one of the things that we looked at, my role when I first came to the council was focused specifically on COVID. And one of the things we looked at were these crisis standards of care that are implemented across all healthcare systems. We think about them a lot in hospitals, and I think many of us really, I certainly was first introduced to this phrase of crisis standard of care, that outside of an acute crisis, when we think of a natural disaster, typically is when this phrase had crossed, my understanding. But that when you delve into what this is its allocation of resources based on the likelihood that somebody will survive. And that we know, because of these generations of health inequities, that people experiencing homelessness, particularly BIPOC people experiencing homelessness, would have been deprioritized for life-saving measures because they have far more health conditions that would make them less likely to survive that medical intervention. And it was this clear example of a prioritization of a value statement in many ways, of a prioritization of who was worth living and what type of life was worth saving. And this statement that those individuals who had more complex health conditions and would be less likely to survive in a manner that we had determined was worth surviving, that they should be deemed deprioritized for these life-saving interventions, as opposed to, and that's not just a matter of do we do it in the moment, but that those crisis standards of care actually would make it so that it were something to change in the course of their medical trajectory at that point of intervention, that decisions could be made utilizing that crisis standard of care. So it's not just in a one-time moment, do we have this resource or not, but that it becomes an ongoing decision point that could be implemented in their course of treatment that devalues people of color, people experiencing homelessness because of these complex health conditions that in many ways our systems have caused or certainly exacerbated. And that was humbling and disturbing and just absolutely horrifying to think of those implications in what seems like, and those are people who would have had to uphold those standards. And it's not the people who wrote them or the people who made the decisions to put them into writing, but the practitioners, the healthcare providers that would have had to carry out those criteria or those policies. And that is significant moral injury caused to that practitioner. But it really speaks to, as systems, who we value, and makes a real clear, there is a whiteness in those structures that prioritizes white people and healthy people as being more valuable to our society.
Thank you, Katie. All right, next slide. We wanted to make sure that you were not coming to this webinar and just hearing from the council. And so we are so thankful for Omar joining us today to share a little bit about some examples from what they experienced at Boston Healthcare for the Homeless, the Barbara McGinnis House. So Katie is pulling up your slides, but Omar will hand it over to you.
Hi, everyone. Again, my name is Omar. Hope this example serves as a relevant experience for most of you. So I'm going to talk about the transformation of the peer support component in respect to the COVID pandemic. I think that this picture represents for me my moral injury very clearly. So this is our standalone respite program. Our respite program is the second, third, and fourth floor. And the first floor is our biggest outpatient side, dental clinic, our sedation monitoring clinic, and the community pharmacy. During the first 2 months of the pandemic, specifically by April, basically 40% of the patient population, the homeless population in Boston, 40% were COVID positive, because we have big outbreaks in the shelter system. So the way I was thinking about this at that time was almost for every 2 patients that come in, 1 of them is COVID positive. The other relevant thing about this picture, and again, it's the frustration for all of us as homeless providers, was the lack of resources and the lack of commitment from our city agencies and state agencies. For example, in COVID, for us in Boston, what happened is that behind this building, the city created what they call this comfort station, that is basically a cage, a fence cage, where homeless folks were allowed to go in and openly engage in drug use. Unfortunately, you had 500 people behind this building unwilling to go to be in isolation, even with COVID. And you had that reality, right? You had this debate of how can we better serve those, when in reality, we needed to be the ones providing the COVID care for the city, because the city didn't have anything to show for. Still to this day, we are the only isolation site for people experiencing homelessness with COVID in the entire state. So that says a lot. We're 3 years into the pandemic, and still the city hasn't stepped up. Next slide, please. So the objectives is just to talk a little bit about Consumers Advisory Board, how they are involved in our operations, understand how a peer component can facilitate recovery groups in respite, how this changed during the COVID pandemic, and the role of this peer support component or a CAP member during the COVID pandemic or restrictions. So briefly, we were the first ever consumer advisory board in the nation. We started in 1993. We embrace this effort and this component. At the end of the day, we are not, our consumers are the experts of what they struggle with, not us. So it should be on them to let us know and to guide our efforts. For us here, our CAP members meet monthly. When it comes to respite in particular, we intentionally have been very inclusive in having our consumers be part of our program developing. So basically, our consumers are part of our weekly leadership meeting, where we go over plans and things that are happening in respite. The CAP is tasked with coordinating and participating in focus groups, health fairs, special events, and in the case of COVID, support groups and commitments. And again, our CAP members are actively involved in all aspects of our program, not only respite. Next. So with the help of our behavioral health team, one of our CAP members was designated to start peer recovery groups in respite. By 2015, we started bringing AA and NA commitments to respite. This was purposely done in the evening when we had less resources and programming happening. The CAP members developed relationship with local recovery meetings, coordinating, scheduling, and connecting with 12-step group programs, and we brought them to our respite operations. By 2017, from 2 meetings that we had a week, we grew up to 5 meetings, and this is not including special events. And again, we're going to talk the impact of COVID with all of this. Next slide. So pre-COVID, right? The CAP member will work with the volunteer coordinator to identify appropriate volunteers that were committed to serve our community. We are fortunate to be the city of Boston, right? We are fortunate to have so many teaching hospitals in the area. So there was a lot of buying of people and volunteers willing to chip in. The qualifications for a volunteer, they needed to work at night. They needed to feel comfortable working with people experiencing homelessness and actively engaging in drug use. And they needed to be committed to recovery and homeless patients. Next. So this is an example of what was happening pre-COVID, right? We had annual special events available for all respite patients, from stigma surrounding addiction, McGuinness House, annual flu presentation, World AIDS Day, Alcohol Awareness Month, overdose prevention event, and Recovery Month events. Important to mention, all of this is managed, coordinated, and organized by our consumer advisory board, obviously with the help of our behavioral health team. Next. This is an example of what was happening on February of 2020, before we were hit by COVID. So you can see that almost every day we had something happening, right? I think that this is a very good example of the effort and the commitment to bring this peer component into our operations. Next. So then the reality of COVID hits our respite program, right? Early March, we had a big outbreak in the city of Boston. There was a big conference that happened, and that's how the virus got into our city. So by early March, we needed to set up a mandatory town hall meeting for all patients, where we were going to start talking about the restrictions that were being proposed and to have a better sense of how the patients were going to feel. There was a lot of fear that we will not have the willingness of patients to come in to such a restricted program. By March 9, patient restrictions were put in place. By March 13, we opened our first version of the COVID-19 unit, the first in the city, with 9 beds. Already by April, we had, from 9 beds that we had in our COVID unit, we went to 13, from 13 to 26, and by the middle of April, we took an entire floor for COVID care. Important to mention, at that time, the biggest shelter in the city had a big outbreak. So the same day that we opened the unit, the entire 52 beds, by 1 a.m., the entire unit was full. Next slide. So What were the early respite risks that we identified? Unfortunately, we needed to eliminate all AA and NA recovery meetings. No volunteers were allowed in our facility. And as much of us know, our volunteers are essential to running a respite program. The patients were restricted to their rooms. They were not allowed to go to the second floor. In our respite program, we have a big second floor that is just designated for the patients to be able to spread out. We have activity room, we have a pool table, we have a dining room, we have an outside patio where patients can smoke. No longer they were allowed to use the second floor. No support groups. We have daily support groups run by our behavioral health team. We have 2 groups every day, and in some cases 3 groups a day. CAP members were not allowed to come to our facility. So the person that is designated to do this no longer was able to come in. And others commitments not allowed were the Sunday service, the therapy dogs, the writing groups, and the bingo activity that for us here in Boston is the most popular one. Next. So this is a picture of what our COVID unit really looked like. Basically, we contain the unit by plastic barriers. And it's crazy to think that something as simple will allow us to serve our patients, but it did, right? We were able to consult with the infectious control team at BMC, who provided guidance through all this process. The most difficult component for us that fall under me as my responsibility of operations for everything that is not medical was non-clinical staff willing to work, right? Food services, housekeeping, security, front desk. As an example, we have an outside vendor that provides our security services. And when we opened the unit, no security officer were willing to come and work. So for the first month, I served as the security officer. So we didn't have, in order to keep everyone safe, because we never stopped respite care. So in order to keep the respite component running, because we knew that we needed to serve our folks and at the same time serve COVID, we needed to change how we were going in and out of the building. So to go to our COVID unit, you needed to actually come through the basement. And then the security searches were done there. That first day that we opened the 52 beds, I had a line of 35 people waiting to be searched in the basement without security because I didn't have no one, right? So the housekeeping also proved to be very, very challenging. As a matter of fact, was the last thing that we were able to put together in order to open the unit. So we needed to go and hire an outside vendor for this. And with food services, we just needed to reorganize the operations to make sure that the staff felt safe. Next. So what needed to happen, right? We needed to provide a safe space for staff to be able, caring for COVID, to do what they needed to do, right? Like PPE storage, and to take new infectious control measures. Trash disposal was completely changed. Meal deliveries, what they were at bedside. Coffee stations and snacks. We needed to triple the snack options. We needed to put a coffee station on the floor. And remember, we are asking for social distancing and for infectious control measures, but at the same time, we needed to deal with the patient experience and how we were going to accommodate the needs and the expectations of our patients. Sanitizing of common areas, how many staff we needed to deploy to do this, and the movement through the building. As I explained, one elevator was exclusively designated for COVID. So that elevator was working only in the basement, and it was locked in place in the basement. So the entire 4 floors for regular respite, and outpatient care needed to happen differently. Next. And if I know that I'm running with this, I want to give enough time for questions and answers, but if you have any question on the moment, please feel free to stop me. So patients were restricted to their rooms. We didn't have enough respite staff to manage the new operation, so we needed to deploy staff from other departments to help run the COVID unit. And as I say this, right, we are running a COVID unit within our respite program, but our program, Boston Healthcare for the Homeless program, was also designated by the city to manage 500 beds as a unit by the city in the convention center. And at the same time, we were providing guidance to the Boston Medical Center on another COVID unit that they had for homeless folks. So we were really stretched out at this point, right? So when it came to COVID in respite, we needed to figure out how we were going to be doing laundry. So I needed to designate a staff member from another part of the program just to do laundry on a daily basis. The methadone in-house, how I was going to make sure that I was going to have enough support to pick up the methadone and have the methadone in-house. I didn't have enough personnel, so I needed to deploy staff from other departments, from other programs. Behavioral health proved to be essential when it came to isolation and to all the restrictions that were in place. So when we started the unit, we didn't have any behavioral health component within the unit. By the third, fourth month, we had 3 behavioral health clinicians inside the unit. We needed them. Transportation services. We all were doing transportation services because, again, the city didn't step up. We have the units, we have the beds, but there wasn't the infrastructure to provide transportation to bring all of these folks to the different COVID units. So who was doing transportation? Me, my CEO, my COO, my chief medical officer. We all needed to do this. And the elevator monitoring. It sounds simple, but you actually needed someone inside the elevator, managing the elevator, sanitizing the elevator after every use. So it proved to be that was one role by itself. Next. So what we needed for staff, trauma support. It was in COVID that we recognized how much needed was trauma support for staff. So we actually brought in trauma specialists on a weekly basis to provide support. Free meals every day for all staff, right? We're asking you to come to work when there is a ghost town out there and all restaurants are closed, so it was only fair to provide them with free meals. Therapy dogs. We were not doing it for patients, but we needed to do something for staff, so we brought that for staff. Support cards. We started reaching out to different community partners around the city, including schools and hospitals and even local businesses. Like, can you please write something nice that we can show to our staff? And we started posting all of that to the program. Time off eligible. If you were not feeling safe to work, we provide you with time off. A hazard pay, everyone got additional pay. Recharge room. It was at that time that we decided to create a room for people just to recharge. We have a recliner, we have soft music, we have light, like soft lighting, and you can just sit down, take 15 minutes, and just breathe. Transparency with program modifications. In order to have the buy-in and the confidence of the staff, we needed to do weekly meetings. This proved to be essential for non-clinical staff. So many times we give for granted this component of our operations, but if I don't have housekeeping, the doctor will not feel safe coming into work, right? And weekly, I have my medical director, Dave Monson, who was our medical director at that time, and me meeting with housekeeping, meeting with kitchen staff, meeting with transportation support, meeting with secretaries. That proved to be essential because by the middle of the first year, everyone came back to work. Next. So the patient experience had a big impact to COVID, right? Patients were restricted to do regular respite stuff. So patients were asked to remain in their rooms, minimal time to spend outside. So over time, as we learned that more about COVID, we feel more comfortable bringing back some of those things that we put a stop on. So that's where our CAP member started coming in back and helping us. Next slide, please. So welcoming back our CAP members, right? Normalizing the peer support within the COVID restrictions. So patient supports were rapidly identified. So what we needed to do, right? Patients like groups. We cannot bring the groups to the second floor. All right. So how many times we hear this concept that let's bring the services to them. So we did the same. The groups started happening on the hallways, on the patient rooms. So we're saying that you are limited to your room. Okay, step out of your room. You can stay in the hallway. Let's do the support groups. Laundry. Our CAP member started chipping in with the laundry. So sounds easy, but when you have 104 patients and only 4 washers and 6 dryers, believe me, guys, it's a lot of work. And our CAP member immediately jumping to support with this. And with the help and leadership of our behavioral health team and our CAP member, we started bringing commitments back to Zoom. We started bringing back spiritual care and Sunday service through Zoom. Cigarettes, we started providing free cigarettes for our patients. So patients were not allowed to go out. And we allow our patients to go out twice a week to go and buy toiletries, cigarettes, and that kind of stuff. With COVID, we were not able to do that. So we started purchasing the cigarettes. As a matter of fact, we purchased cigarettes for 2.5 years. Guys, we spent over $100,000 in cigarettes alone. More food options, right? So you're restricted to your food. Why don't we do cool stuff? Why don't we do Taco Tuesdays? Why don't we bring chocolate bars? Why don't we bring ice cream? Why don't we bring I remember having fried calamaris, guys. Well, we had so many food options, and thank you to our kitchen staff that went way beyond what we expected. And to make it even more appealing, they were not only serving the patients more options, they were serving all the staffing. And that's incredible. More activities on the floors. So why don't do bingo on the floors, right? So we did that. McGuinness Gazette. So basically we created this package with the help of our volunteers remotely and our CAP member who actually led these efforts to put together a weekly McGuinness Gazette. It's basically a fun package full of things that you were like word puzzles and stories of patients and poetry from patients or drawing from patients. So it was done by the patients for the patients. And at this moment, we created a welcome package. Not sure why we didn't have it before. I think there is something that a lot of other places have done in the past. We didn't have it. We decided to create a welcome package, just sharing what we are and what we're doing to the COVID restrictions. Next. So again, the peer support component during the COVID-19, there were some of the activities that we brought together. Once we felt more comfortable, we We opened the second floor. As long as we had mask wearing and social distancing, we felt comfortable using the second floor space. So we started doing special events. One of those was what does recovery mean to me, and role of Suboxone in recovery, and recovery meetings bi-weekly. Yes, next. Hidden surprises. Yes, there were good things that happened from COVID. Higher attendance. By having the meetings by Zoom, more patients were allowed to access the meetings. So patients were provided with laptops. So there were laptops in each room. So more participation, more people were engaging in the meetings. There were more access to meetings, and there were more meetings offered because they were by Zoom. Next. This is some of the special events, and this is something from the patients, right? My life is very important to me, and I'm a mother and son to be wife to my love of my life. Next. This is some of the examples of the patient's input. This is what recovery means to me, that event. Next. This is asking for feedback when it came to the Zoom meetings. There you can see how the positive input was from the patients. Next. Zoom meetings are very good. Next best thing to being alive. So, right, we were hearing directly from the patients, and they were showing their appreciation. Next. And this is another example. And yes, next, I think that's it. And you have one more here. Yeah, so thank you. Again, so even through the fact that we needed to eliminate this peer component to respect, by half of the first month through the COVID pandemic, we recognized that the patient experience was really taking a toll, and we needed to bring back some of these resources. And honestly, the peer component was instrumental in helping us still to this day be able to provide these support systems while you're in quarantine or in isolation because of COVID. So yes, thank you. That's it for me. Any questions, comments?
Thank you so much, Omar. I don't know if you had a chance to see the comment in the chat that your team did an exceptional job and jumped right into action when everyone was trying to figure it out. So
thank you.
Just wanted to make sure you saw that.
Yes, 100K for 6. Yes, believe me, and I was managing that budget, so it was hard. It was hard, but I tell you, it did have such an impact on patients. We allow patients to smoke. At the end of the day, our primary goal and mission is access. So I'm not going to limit access based on the fact that you cannot smoke. So I'd rather have you come in than not come in because of a cigarette.
Thank you. I know that we have about 6 minutes left in our time together. So if anyone had anything that they wanted to share, please feel free to raise your hand. I know Kivanya had a couple of stories that she can share, but just wanted to give space. Yes, Barbara.
Hi, everybody. I'm Barbara DePietro. I'm the Senior Director of Policy here at the Council. And Omar, thanks for that presentation. I just want to give a shout out to you and your entire team at Boston Healthcare for the Homeless Program. While Omar was doing all of this, while the team was doing all of that, They also worked with us at the council consistently. Even in the thick of your response, you joined us for national calls. You've joined us with the CDC throughout the COVID response. Your whole team was responsible not just for informing national policy and guidance coming from the CDC, but you led the way by providing an incredible example. And I just remember, again, even in the thick of everyone responding to this and no one knowing what was going to happen, you guys were selfless with your time with us at the council and with the whole HCH community. And I just can't say enough about how wonderful that was. And your partnership and leadership there was just so appreciated. So thank you so much, brother. I really appreciate it.
Much for your kind words. I do have to say Jesse Gaeta, who was our chief medical officer, and Barry Buck, who was our CEO at that time. They were leading by example. They are the ones that make this program run through all that crisis. So thank you for sharing that. We just follow their lead.
You can take a little credit. Right. Anyone else?
I'm just going to say, I'm going to please chime in. We'd welcome. I am going to launch our poll just with our last. Yeah, perfect. Sorry, Laura. Didn't mean to.
No, perfect.
Yeah, just we so appreciate if you can complete. It's a quick 3-question poll. Our evaluation for HRSA. So important to get your feedback. But please, also, we welcome you to continue to share, to come off of mute or hop into the chat, whatever's best for you. And also, rather than sharing our screen, I'm just going to drop a link in the chat, a reminder. We are very rapidly approaching our annual conference in May this year, and would love to see you all. It runs from May 15th to the 18th. We have a day of pre-conference and then 2 days of what we call our main conference, followed by a half day of learning lab. And would just love to see all of you, welcome you to Baltimore, show off the amazing Baltimore HCH, and just get to learn and spend time with one another. As we have learned through this moral energy, it is community that helps us pull through those moral injuries. So.
I want to thank you all again for joining today, for providing your feedback. Thank you again to Omar for sharing all of the incredible work that you all are doing in Boston. And just want to say that if there is anything that any of the folks joining today would like to see from the council related to moral injury, we would love to hear that feedback from you. So please feel free to put some thoughts in the chat or reach out to us afterwards. We want to be a resource and recognize that this is a particularly difficult area to find some resources, and would love to use this community to build that up more. So please feel free to reach out. I'll put my email in the chat as well. But just appreciate your time and hope that you all have a wonderful day.
Be well, everyone. Thank you for being here.
Thank
you, Omar.